Okay, today we are going to try and unpack digital health, or mHealth, which I think are cousins of each other. And we'll try and unpack this and look at them as conduits to delivering health to where young people are. And I have no conflict of interest to declare. This is the outline that I will follow. So I will just move on to the next slide. Okay, sorry. There. So I'd like to start by defining what mHealth or what digital health is. For the purposes of this presentation, I will mostly refer to mHealth, but like I said, I look at them as cousins of each other, okay? And there are numerous definitions of what mHealth is. However, I like this one that is beautifully crafted by WHO. And it defines mHealth, and this is what I would like for you to look at mHealth as you think of it in an African setting, as you think of it applied to young people. So WHO defines it as the use of mobile technology to provide healthcare support to patients or technical support to healthcare providers in a direct and underlying low cost and interactive manner. So that is how I look at it when I look at reaching young people in the context of Africa. In the last decade, mHealth has gained a lot of traction in Africa, and some of the reasons are very unique to Africa. What we see a lot of infrastructure barriers to access to healthcare. We see especially geographical, poor road networks, we see physical barriers, and in the recent past, lockdowns, and as well as shortage of health personnel. So mHealth provides a means of leapfrogging some of these barriers in order to provide equitable health care. And also in the recent past, we've seen a change in tides where phone penetration is higher than penetration of sanitation and even water access. So about 48% of people in sub-Saharan Africa have access to phones. And this is a great resource if you think about reaching everyone and not leaving behind anyone who is held back by these infrastructure barriers. So this change in tides has made it possible for mHealth interventions to thrive and make it within the African youth. And then, of course, there's been increased research. So science is driven by research, medicine is driven by research, and we only do things that have been proven to work. So there's been an increased research, especially in the areas of efficacy and acceptability. So the big question is, does it actually work? Do we think this works? So I will try and unpack the literature in a few slides to demonstrate if mHealth actually does work. It might be something we are discussing, but does it work? And I'm sure the presenters after me will give their work and they'll talk about whether mHealth works in this population or not. So I'll start by going to Southern Africa and looking at a qualitative study that looked at the acceptability of a tablet-based application to support early HIV testing. And in this qualitative study, what they found in men 15 years and up, there was high acceptability of this tablet-based intervention. And then I will move up to West Africa and look at a social media-based intervention called the Smart Connections that enrolled 349 adolescents and young adults aged 15 to 24 with HIV and in care. And this intervention was delivered via small Facebook groups. It was a modular intervention delivered by a facilitator, and the endpoint or the outcome was looking at retention in care and ART adherence. What they found at the end of follow-up was that there was actually no difference between the two groups. However, what they found was that there was increased knowledge of HIV in the group that received the intervention. Then I'd like us to move to East Africa and look at a study by Jessica Mbarara et al. That was an RCT that was SMS-based, one-way SMS. And the outcome of this study, the endpoint was to test PrEP adherence among young women aged 15 to 24 in Kenya, in Kisumu and Thika. And what they found, that there was actually no difference between the two groups. Then we move on, still within Kenya in East Africa. And this was a two-way RCT, SMS-based, that looked at women who were pregnant and those who were postpartum, still young women, and who were taking PrEP. And the outcome in this study was to look at one, retention, PrEP retention, and then two, PrEP adherence. And this study actually did demonstrate that there was indeed improved retention in PrEP and adherence in the group that received the intervention. Then I would like us to look at now more data. And here we are looking at a systematic analysis of interventions in low and middle income countries. So in this particular analysis, 27 studies were included. And what they concluded from this analysis was that there was high acceptability, there was high feasibility. However, results were conflicting. And this was mostly due to designs. And some of the issues with designs included being underpowered, included being uncontrolled, and the fact that there were no principles of implementation science that were applied to these studies. So back to our question, does mHealth actually work? What we can say with confidence is that we have high acceptability of mHealth interventions among youth in Africa. However, results are mixed. What we can say is that when mHealth interventions are well designed, they have the ability to decrease disparities in the HIV continuum of care by young people in Africa. And what we clearly see is that there is need for larger and well-designed mHealth interventions that target specifically young people in Africa. I will use 2 case studies of studies that I have conducted in Uganda that will try to understand some of the pitfalls and how you can successfully implement mHealth interventions within Africa, in especially low resource settings. And I'll start by looking at a study called the PRADA, the pandemic. So this was a study where we tried to describe disruptions in care that happened when during the lockdown among adolescents in our HIV clinic. And then we explored qualitatively if mHealth interventions had the potential to bridge disruptions in care. So the study methods were that we enrolled 13 to 24 participants, 86 in total, at that small clinic that you see. And we used a mixed method design where we followed up participants at 0, 3, and 6 months and conducted 35 qualitative interviews. The outcomes were we looked at the proportion of services that were disrupted. We looked at ART adherence, and for this presentation, we looked at acceptability of mHealth interventions to improve these disruptions in care, or to bridge the disruptions in care. This analysis is still in progress, but I'll present some preliminary data. So we see 51% were male, and mean age was 18. Importantly, I would like you to see that we have phone access of 60%, okay? In this population aged 13 to 24, we had phone access of 60%, so very good phone access. And then we had internet access among those who had phones of 70%. So this is a resource that we can actually use to deliver health care. Those who missed a scheduled visit were about 27%. In the qualitative arm, what we found was that there was a high acceptability of mHealth interventions, and participants thought that these were very important, especially in bridging the gap in care that occurred during the lockdowns. And I'll quote some of the quotes from two of the participants. So one says, "But if she, the counselor, is calling you, she could constantly give you advice and give you reminders on ART adherence." And then another one says, "I think costs were cut as I received the treatment while I was at home." Then I look at another one called the USmart, which was an adaptation of the smart connections that I had described earlier on that was conducted in Nigeria. So in USmart, we tried to adapt the smart connections intervention to develop USmart and test its acceptability. So we developed a 12-module intervention that we used on WhatsApp. And we've so far enrolled 20 adolescents and young adults with detectable viremia, and we are following them up to see if their adherence will improve. And we shall measure adherence by looking at levels of tenofovir in their blood levels. And subsequently, we also enroll 20 adolescents and young adults and their caregivers to see if this intervention actually applies to caregivers as well. Those were some of the targets of the USmart intervention. So what were some of the pitfalls that we've experienced in these 2 studies and that other studies have also experienced? One is during some of the qualitative interviews, we found that parents and even caregivers, and even healthcare workers have a negative perception of adolescents and young people using phones or having access to internet. So we need to find a way of dealing with that. Then there are sustainability issues. We had a lot of times when adolescents couldn't be reached because they couldn't afford the data, okay? But also scale up issues, so at a higher level than just your health facility. Is the government able to support this? Is your hospital able to support this? Infrastructure issues like reliable internet, and then the hardware that is sometimes required. Then usability, thinking about the font size, the language you're going to use, the cost, high internet costs, having to charge your phone every now and then. Still, there's lack of theory-driven and tailored interventions for adolescents and young adults. And then sometimes there's lack of policy and institutional frameworks to guide even these studies. And then sometimes when I design an intervention, she designs an intervention, these two cannot communicate with each other. So we need to think about how interventions should be designed in order for them to communicate with each other, okay? And then the big elephant, ethical issues. So protection of personal data. And adolescents need to be comfortable and know that their data they're giving you is actually protected. Some of the considerations that we considered while implementing these studies was using available infrastructure. We thought WhatsApp was ubiquitous, and we thought it used less data compared to other social media platforms. Our interventions were grounded in theory. And then we involved adolescents and young adults and other stakeholders, including the counselors themselves, at the inception of the study. And then we ensured that there was data protection that was guaranteed. So we taught the adolescents from the beginning how to safeguard their phones against third-party access while using WhatsApp. Then I would like to touch upon artificial intelligence and mHealth. This is something that has become more and more popular. So we'd like to acknowledge that it's becoming, widely used, and we should also think about, moving in that direction as well. So AI is basically simulation of human thinking processes by machines, especially computer systems. And increasingly, we are seeing AI being used for disease protection, management, using data that is mHealth generated. And it has become popular in Africa. So I looked up the literature and looked up what was available. And what I found was that there are very few AI-powered mHealth interventions, and most are mainstream, things like ChatGPT. However, some are locally directed, like the Afya Pap, which is popular in Kenya and in Uganda. Some of the advantages of AI include it can be detail-oriented and is very good at diagnosing, especially it has been piloted in breast cancer diagnosis and other cancers. It saves a lot of time and can go through a lot of data that is collected in a very short time as opposed to a human being. It could be an avenue in which, a health worker may pay attention to something else, as the chat box, for instance, delivers information to the adolescent. So it allows health workers to focus on something else. And then so it doesn't get tired, it doesn't sleep like human beings, and the results are consistent. But it goes without us saying that there's a downside, and sometimes usability issues may come up in that you require a level of literacy. It's very costly, and the algorithm might not be personalized. And then it has room for large-scale bias, so a bias may be amplified when you're using AI. And then lack of generalizability. So the fact that a study or data was collected in a high-income country, that data may not be applicable, or the algorithms may not be applicable to us. Then there's also confidentiality and health data security issues to consider. In conclusion, I want you to know that mHealth is not a panacea, it's not a fix for everything. And then before you develop an mHealth intervention, ask yourself if this is what you really need to be doing, okay? And is it something that will work for adolescents and young adults in your setup? And remember, it's always good to look into your box of interventions and pick what has already been done. Don't try to do something very new. And then to conclude, always make sure as you're combining mHealth interventions, combine them with existing interventions like community outreaches, disintegration the differentiated model that is currently available. So combine interventions, don't just try and use one in isolation. And this will promote synergy and increase acceptability. I'd like to acknowledge conference organizers, my mentors, and my funders, as well as participants. Thank you.